I'd like to welcome Kawena for our Oli today. If you guys want to, everyone stand up. And it's also custom to take your sunglasses off your head, and then if you want to, keep your hands out and open. Mahalo.
E ho mai ka ike mai luna mai e o nā mea huna no eo o nā mele e ho mai e ho mai e ho mai e ho mai ka ike mai luna mai e o nā mea huna no eo, o nā mele e ho mai, e ho mai, e ho mai, e ho mai ka ike mai luna mai e, o nā mea huna no eo, o nā mele e ho mai, e ho mai, e ho mai e pule kako. E ko mako mako I loko ka lani, e ho ano ia ko inoa. E hiki mai ko aupuni, e malama ia ko make make maka honua nei. E like me ia I malama ia makalani la. E haawi mai ia mako I kia la I aina mako no nea la. E kalamai ho ia mako I ka mako lawehala ana, me mako e kala nei ka po e lawe hale I ka mako. Mai ho oku o ia mako I ka ho vale vale ia mai, e ho pākele no na ia mako I ka ino, no ka mea nau kia upuni, a me ka mana, a me ka ho onani ia maulu aku. A mama ua noa. Mahalo.
Mahalo, Kawena. You may be seated. So good morning again, aloha kakahiaka, mahalo again, Kawena for our Oli today. My name is Rachel Secretario. Can you do the oh-ohs? Yes, we're gonna have a good time today. Let's get ready. I just love health. We're gonna have a great time. We are honored to be, I am honored to be your MC today. The Kauaʻi Rural Health Association, mahalo to KRHA, is proud to host the 3rd annual Ola Pono o Kauaʻi Conference here at the Kauaʻi Community College Performance Arts Center. Let's give ourselves, let's give them a round of applause. 3rd annual, it's pretty exciting. So today we gather to explore our theme, mental health through the lifespan. An event like this is not possible without community support. We'd like to extend our heartfelt mahalo to our sponsors, Kauaʻi Community College, the Kauaʻi Resilience Project, Ho'ike, Hawaiʻi Rural Health, and Ho'ike Kauaʻi Community Media, and the County of Kauaʻi. Let's give them a round of applause. And to officially open our conference, it is my great pleasure to introduce the Mayor of the County of Kauaʻi and Niʻihau, Mayor Derek Kawakami. A 3rd-generation Kauaʻi resident, Mayor Kawakami has a long history of public service, having served on the Kauaʻi County Council and the Hawaii State Legislature. On November 8th, 2022, he was re-elected to a 2nd term as mayor. Please join me in giving him a warm welcome. Oh, hello. Oh, hi.
Oh my gosh, I cannot believe that after all these years, I still have waves of anxiety. Anytime I gotta get behind a podium and address the public, I don't know what it is. But Rachel gave me a helpful tip that I didn't even use, so let me try and do it. It didn't work. You know, people ask me, how do I do this job, which I don't even consider a job because I love it too much. And I was always taught that you're not supposed to love your job too much because it might look like you're playing. They asked me, how do I get through the criticism, the harder, challenging times, seeing hardship and people struggling and still remain positive? Well, I know that we live in a world that can seem very complicated, especially for our young people. And when I look into the audience and I see our younger people, I can say and attest that it is much more complicated and challenging to be young today than it was when I was growing up. But I just live by two phrases that, I don't know and they don't know. And for some reason, it helps me have empathy and patience and to understand that most of the things that people may say that are unkind, they really don't mean. I don't know what this person is going through. They may be having just the junkiest day of their life, and they just may feel like nothing is going right. And they don't know who I am truly as a person, and if they did, they probably wouldn't have these feelings. And I got to remind myself every day that people are struggling, a daily struggle. And I know this because I myself have had my struggles that continue on to this day. I want to thank the prosecuting attorney's office and Michael Miranda, but I want to thank everybody that has come together as a community to address our mental health needs, to uplift people's spirits, to bring hope into people that may feel that there's no hope left. Because it takes a village to raise a village, and this is truly a wonderful, wonderful village. For me personally, genetically, and I don't know what it is, but on my mom's side of the family, we cannot touch anything that feels good. We have that addictive personality. That, for some people, they may say, hey, that's a good thing, because when you put your mind to something positive, you go all out. But on the flip side, it's such a challenge that, for one, I can never have a glass of wine. And I know this because one glass of wine will turn into 2 bottles of wine. I just can't touch it. For me and my family, I've lost 5 family members to suicide. 3 cousins, an auntie, and my older brother. And when I was younger, it was taboo. It was prohibited, almost shameful to talk about it. But it makes me, I have a renewed hope that in this day and age with this community and all of your organizations, that we start normalizing the conversation about mental health, substance abuse, addiction, and that people are not necessarily bad, but they're just in bad situations. I want to thank the organizers, and I also would be remiss if I didn't thank KCC for allowing us to use this venue. And if there's any legislators or elected officials out there, we have our work cut out. And I hope that they take what we learned from you today and apply it into our daily work and keep on pushing for this island and rural mental health. If there's any psychiatrists in the audience, I hope what I'm about to say doesn't offend you, because it is not intended to. But for one example, for years when we were in the legislature, we had identified that mental health needs in rural communities such as Kauaʻi were far and few between compared to the big city of the city and county of Honolulu. And so we tried to pass measures to allow psychologists, under the care and guidance and supervision of a psychiatrist, to have limited prescriptive authority. And in those hearings, I would see outside psychiatrists, maybe not even from Hawaii, but mostly from cities, testifying against it, saying that if psychologists want to be able to prescribe medication and help their community, they should go to school. For somebody that has lost their brother, a family member, or friend to suicide, and knowing that he or she was trying to find help but couldn't navigate their way forward, that is probably the most heartless thing that you can say. And like I said to our psychiatrists here, it's not intended for you, but these are the type of battles we're up against. We're up against battles where people are trying to protect their territory, not seeing the bigger picture, and we just need more people like you to advocate for rural mental health. With that being said, I want to congratulate all of you folks for making it here today. This is an issue that is very near and dear to my heart. And for the young folks that took time out of their day to be here, you give us all renewed hope that we're heading in the right direction. With that being said, thank you so very much. God bless and aloha.
Thank you so much. Mahalo. It didn't work. Oh, sorry. Maybe just make a funny nose. Ha ha ha. I do stand-up comedy, so I was trying to give the mayor a little bit of advice, but it doesn't usually work for stand-up comedy and public speaking sometimes. Let's give him another round of applause. Hey, oh. Well, fasten your seatbelts. You stay right here. We have, I would like to, for our first session, focus on adverse childhood experiences. Our speaker is Dr. Kaleka, a psychiatrist and a family physician with Hawaiʻi Health Systems Corporation. Here on Kauaʻi, Dr. Kaleka is passionate about helping people heal holistically with an emphasis on the impact of trauma. His presentation is titled Adverse Childhood Experiences, ACEs, their impact on mind, body, and spirit, and the pandemic that we should be addressing. Please welcome Dr. Kaleka. Mahalo.
All right. Thanks. Thank you, everyone, for being here and being patient. I'm trying to figure out where to put my water bottle. Yeah.
Here's a clicker for your slides.
Okay. Well,
And this one and this one is the two that you press. Don't press this top one because it'll take it back to the beginning.
okay. Thank you. All right. Yeah. So my discussion today is about adverse childhood experiences. And I am a psychiatrist with Hawaiʻi Health Services, Kauaʻi region here in Kauaʻi. I work from Waimea down to Kapa'a and seeing a variety of patients all across. And, you know, a lot of what I'm going to be talking about is how the adverse childhood experiences impact us and also how we as a community can do something about it. So before we start, I can see most of you in the crowd. Give me a raise of hands if anyone's ever heard of ACEs or adverse childhood experiences. Okay, so a good amount of you. Okay, that's good. So if anything I say is redundant, my apologies in advance. There we go, yay. All right, but hopefully you guys are able to get something out of this, even if you've heard of ACEs. So I try to be very transparent with disclosures. I have a very small financial incentive because technically I have a bonus in my contract based on the number of patients I see. So if any way, shape, or form this results in one of you or a family member seeing me, I guess that's a financial incentive. But really, you know, my big thing is my emotional incentive in really helping our community heal, right? At the end of the day, I say that I would love that we are all doing so well that my job becomes obsolete and I can become a teacher or do something else. I'd be happy to do that in a world where people are just doing well mentally, emotionally, physically, and spiritually. So I do like to give a trigger warning that I am going to be talking about trauma and particularly childhood trauma. And in reality, we all have our traumas. And so if you are triggered by something I say, please give yourself the grace, the space. whatever you need to do to tend to yourself. I will not be offended if you walk out of this room. I understand we all have different needs and different times, and so please tend to yourself. Don't worry about me or ideally anyone else if you're feeling overwhelmed. So this is a brief interview of what I'll be talking about. So my specific interests in adverse childhood experiences. I'm going to talk about the story behind the ACEs study and where that came from, and the ACEs study itself, and then the likely mechanisms of how adverse childhood experiences affect us, and most importantly, what can we do about it? And I would love to make sure that we have some time for questions and discussions. So, all right, so as a physician, I've had my own hurdles in medicine, and probably one of the biggest things, the reason I went into medicine was to really help people live a better quality and a longer life, right? I really wanted to help people live their best life in every way. And when I was doing my training, I realized that a lot of my patients with chronic disease rarely got significantly better, right? I noticed whether they were diabetic and their A1C improved or their blood pressures got better. It was really usually a slow progression of improvement, and I rarely ever saw their diabetes go away or their high blood pressure just go away, right? If anything, we would accumulate other symptoms and other diagnoses and other medications. And so with those medications, and sometimes the diagnoses, you have their own adverse effects, right? So I say it's almost like playing whack-a-mole, right? We think, oh, I'm going to treat your high blood pressure or your depression with this. But now we have diabetes, and now we have other things. And so we're just constantly having these moles pop up, and we're just trying to knock them down. In reality, they're all still there, right? In some way, shape, or form. We're just trying to hold them below the surface. And I realize we're actually just managing chronic disease. We're not actually helping people truly heal from it, right? And this was a huge, some people call it a moral injury. When we go into something with this intention and we just can't do it, and we feel like we've kind of defied our own values and our morals. So I had this epiphany while listening to this book when I was in a really dark time in my residency. I was really struggling in a lot of ways. And this book, The Body Keeps the Score, I really recommend to everyone, again, kind of with a similar, if not more significant trigger warning that it does talk about trauma. But the thing I really like about the book is it gives us hope, and it gave me hope that we can actually heal from this, right? It's not just having trauma and its impact, but how do we help heal it and let that go? So I'm going to talk about the story behind the ACEs study, right? So before the study that we keep calling the ACEs study came about, there's a doctor based out of San Diego, Dr. Vincent Felitti, and he worked as a preventive medicine doctor for Kaiser. That's what KP stands for, Kaiser Permanente. And he worked at a weight loss clinic, and they really had tremendous results, right? They had people coming in with profound morbid obesity, and they were able to help them lose a significant amount of weight. Usually it was a combination of bariatric surgery and a lot of lifestyle interventions. They had a big team, and he was a big part of this team. But he had noticed, and he makes note, they make note in this book, and when you talk to him, he had one patient, one of the first patients he had coming into this clinic, came back gaining more weight than he thought was humanly possible. Right? She had lost over 300 pounds in the course of a year, but she gained it all back within 1 or 2 months, right? And for him, he was just like, what happened, right? And so he sat down with her and he goes, hey, you were doing so good. What is it that happened? And she shared this really profound story where she said, as she started to lose weight and she became more physically attractive, that men at her work and in general were started to hit on her. And started to make, basically show interest. And it brought up a childhood sexual abuse trauma that she had from childhood. And so even though initially she may have gained the weight kind of unconsciously or subconsciously, now she was gaining the weight back because she didn't want to be attractive anymore. She didn't want to even get near what that experience would be like. He basically surveyed everyone at the clinic, and everyone in this clinic had childhood sexual abuse, right? I just want to let that sink in. And him and I have had this conversation where, and I wasn't sure at first, but when him and I talked about it, and I've continued to test this, he basically realized morbid obesity, right? You can talk about BMIs, but really not just like, someone's on the heavier side, but really morbid obesity is not genetic. It's not just lifestyle. This is a bigger, profound phenomenon that exists at a trauma level, right? Often rooting back to childhood trauma. And so he presented this finding at a conference in Atlanta. And as you would imagine, this was in the 90s, or maybe late 80s, early 90s. He got a lot of mixed reviews, we'll just say that, right? A lot of people like, why are you even talking to people about this stuff? What, are you some kind of pervert? Like, he really got a lot of backlash about why are we even talking about people's sexual trauma and sexual abuse as a primary care doctor trying to help people with weight loss. But with that said, there were people who were also very much like, whew, this is, if what you are telling us has any truth to it, including the director of the CDC at that time, they said, maybe we should look into this a bit further, right? So that's what really led to what we now call the ACEs, or Adverse Childhood Experiences study. And so what is the study itself? So I'm going to go into some scientific, some people may call it mumbo jumbo, but bear with me. But we're going to go into the design of the study and the results. I'm going to try to be brief about this. But basically here, you can kind of see it. So they had done an initial survey. They did multiple waves. So the first wave was about, they sent it out to over 13,000 people, got 9,500 responses. And they looked at all the medical evaluations for these patients. And then they did a second wave, which was about 15,000 people. I think the total number after all the waves was about 30,000. So a pretty significant size of study, right? We're not talking about a handful of people here. We're talking about, a substantial cohort. And these are all Kaiser patients, by the way. And so at that time, kind of, socioeconomically, we were talking about middle upper class type patients. So that's going to kind of skew the way we look at this data a little bit. And then they followed up and they looked at their mortality, right, through the using the National Death Index, their morbidity, right, their basically ailments, their disease, exacerbations, hospital discharges, right, who got admitted to the hospital, and then outpatient visits, right, whether it was primary care visits, specialists, and then also ER visits, and pharmacologically, right, their medications. So this was the survey. So it talks about different categories of childhood exposures: abuse, psychological, physical, sexual. Then you go into household dysfunction, substance abuse, mental illness at home, mother treated violently, and then criminal behavior in the household. Did anyone ever go to prison? And I really like to point out these numbers here. These are the more, I'm trying to see the clicker. So just to give you an idea, 22% of those surveyed report sexual abuse or sexual trauma growing up. And then 25% were exposed to some form of substance abuse, and then some sort of mental illness, close to 20%. The reason why I emphasize report is, in my experience in doing this work, and maybe some of you have the same experience, when you hand a paper survey out to people, people aren't always completely honest. And that's one piece. The other part I've realized, and it's particularly common for sexual abuse and sexual trauma, it may not even be recalled. It's probably one of the most commonly repressed traumas, especially if it happens before age 6. And we've learned that in a lot of, kind of landmark lawsuits with like the Catholic Church and these now adults recalling sexual trauma that they had when they were a child. And they're like, well, why didn't you say anything before? And they didn't remember. It was repressed. It was a coping mechanism. And so there's a lot of patients out there who may still, to this day, not know that they were actually sexually abused because their mind has basically shut it out, right? So there's a lot of caveats to this. And in my experience, I'll have someone fill out a paper survey, and then I do my assessment. And they may have said no to all these different things, but I realized in the history that they were physically abused. They don't want to call it that, right? For them, they may just call it lickings, right? That's par for the course. Everyone gets lickings. This isn't abnormal. So they don't see it as the way we question it. But when you dig in deeper, you realize that these numbers are probably higher than what we're seeing here. And again, this is kind of a mid to higher socioeconomic status. So when we get to lower socioeconomic status in different cultural groups that probably weren't incorporated in Kaiser at that time, these numbers are probably going to be higher still. So with that said, I'm going to go through just basically in brief the results that they found in terms of disease risk or behavior risk patterns of people who had 4 or more ACE categories, right? We kind of talked about the different types of abuse, household environment. So 4 more positives relative to people who had 0. Oh, sorry. Oh no, how do I go back? Because I can't hit the other button. Or maybe I hit the other button. I'll just have to go. There we go. Okay. It doesn't go to the beginning. All right, good. So basically, smoking was over 2 times more likely. Severe obesity, again, 1.6 times more likely. Depressed mood, now we're getting even higher numbers, almost 5 times more likely. And then you get to attempted suicide. And this is in adults, right? 12 times more likely. Right? These are, from a public health perspective, this is a huge jump, right? In most studies, when we talk about risk factors, we're usually going 1 to 2 times more likely. 12 times is really on an extreme end. You rarely see this in any kind of epidemiologic study. Considers themselves an alcoholic, right? I think this tells us that they likely struggle with drinking and they have the insight to realize they struggle with drinking, right? So that was 7.4 times more likely. Again, probably relative to people who actually struggle with alcohol dependence or what we now call alcohol use disorder, probably higher. Illegal drug use 5 times, injected drugs 10 times more likely. Promiscuity or high number of sexual partners, greater than 50, 3 times or over 3 times more likely. STIs 2.5. And this is the interesting part, right? Because this stuff, it's kind of more behavior, mental health related. We may expect this. But when we look at other things like ischemic heart disease, right? People who've had a heart attack or have blockages of their arteries causing ischemia, again, over 2 times more likely. Any type of cancer, 2 times more likely. Stroke, almost 2.5 times more likely. Chronic bronchitis, emphysema, 3.9 times more likely. And diabetes also. Right? So this isn't just mental health. This is overall health that's really being impacted. And so just to give you, again, from the original study, 13% had 4 or more ACEs, right? So substantial amount. And 67%, 2/3, have at least 1. And the more ACEs, the more risk for chronic disease. In fact, it is basically linear. You can see the 0 to 5 or more ACEs, right? And then the percentage with health problems, it is basically a straight line. So, again, this is correlational, but very, very linear. So, and ACEs, if they had an ACE score of 4 or more, they're 3 times more likely for heart disease or lung cancer, 7 times the risk for alcoholism. ACE of 7 or higher, 30 times the risk of attempted suicide. Again, we were talking about how these risk factors, and then in child and adolescence, 50 times more likely, right? So people, and this one I really like to point out, people with an ACE score of 6 or higher, on average, die 20 years earlier than people who have an ACE score of 0. Right? This is, from a health perspective, we ignored this data for a long time. There was a big time from the early 90s, really until the last 5-10 years, where the ACEs conversation has come back up, mainly because we all realized, oh, medical technology is not going to fix all these chronic diseases we struggle to do. And oh, let's go back to this huge study that shows there's other things that really contribute to the struggles that patients have and why we can't get them better, right? And why they're dying earlier. So this was their model initially. So they thought the reason for this is people have adverse childhood experiences, right, shortly after birth or early childhood. And then because of that, they develop these social, emotional, and cognitive impairments, right? And then they get into risky behaviors because of that. And this is what leads to disease and social problems, and then that early death, right? This is what they thought at that time. As we've done more and more research, we realize there's other things that are really contributing to chronic disease from the adverse childhood experience perspective, right? And so going back to this book, The Body Keeps the Score, they did a really interesting study where they put people under an fMRI scanner, functional MRI, to detect brain activity, while they recall their past trauma. And some things we saw were pretty expected, right? The fear or the limbic part of their brain lit up like a Christmas tree, right? The fear center, when we're thinking about trauma, clearly that's going to be quite activated. The more interesting parts that I notice is this part of the visual cortex that lights up here. This is associated with something novel, right? Seeing something for the first time or what feels like the first time. That's pretty profound because oftentimes these traumas were sometimes decades before, right? They're not seeing it for the first time, but when they go back to it, it feels like they're still living it, right? And the other part is Broca's area, or our verbal expression part of the brain. That is very diminished, right? So this dotted line is what we would expect normally, very diminished relative to that area. So the way Bessel van der Kolk, the author, puts it is trauma is pre-verbal, right? It's not something we can really put into words. And the reason I make that an important point is we're going to talk about ways to heal from trauma and how that corresponds. And so what happens when we are day in and day out living our traumas, right? Especially if we've had a lot of trauma, right? We activate all this stuff that's involved with our primitive part of our brain, that fear part of our brain, and it drives up our pituitary and our hormone levels, right? And our brainstem and the whole slew of things which tend to kind of cause a lot of stress on our face, right? We always say, oh man, that person looks stressed, right? We can just look at their face. Sometimes people use the term RBF, which I'll leave to you look up so I don't have to offend any people here, in case there's any kids in the audience. But it can really affect the thyroid, right? So the thyroid is a big part of how we function. Heart, lungs, right, or the lung disease we kind of insinuated, and gastrointestinal, right? And we're going to get into those diseases that we see, but common things like IBS, but going all the way to Crohn's disease, right? Chronic constipation, all these things that people struggle with. And then adrenal glands, right? Our stress hormone production centers. Right? Has anyone heard the term adrenal fatigue? Right? We're stressed to the point where we're just exhausted, right? And I want to keep in mind, right, our response to these traumas are originally they're very primitive, and they really helped us survive at that time. The challenge is now we live in a world where our lives are not maybe physically in danger as much, but we're often perceiving it as such, right? The stresses of work, the stresses of family. It feels like life or death sometimes, mainly because our physiologic response, we don't have those saber-toothed tigers chasing us down or these other things, so we start to interpret things in our normal everyday environment as these kind of stresses and triggers and danger signals. So I'm going to get into how this can just manifest in some of the diseases. So when you increase hypothalamus and pituitary activity, cortisol levels, and how sensitive you are to cortisol. That increases fatty tissue and obesity in your tissue, right? So again, the reason why morbid obesity is not just all lifestyle is you're actually having physiologic changes from living the trauma. It increases cholesterol levels, glucose, and that can lead to insulin resistance, which we often associate with diabetes, right? And then these inflammatory factors. And then when we increase adrenaline, epinephrine, norepinephrine, we get vasoconstriction, right? Tightening of our blood vessels, right? And that leads to high blood pressure. And really all these things are going to contribute to our heart disease risk, our stroke risk, our kidney disease risk, all these other diseases we don't often think about with trauma. So I always like to point out this trauma loop that we have. So you have a traumatic event, and trauma is all subjective, right? I really want to emphasize that. What may be traumatic to you may not be to the other person, and vice versa, right? So, and the reason for that is we perceive an event, or an event can be stressful, right? But if it's stressful to the point where we feel like we have no support, right? Like almost like we're free falling, that is going to make something really traumatic, or insufficiently supported, let's say, right? The notion from I got this because I have the resources and support I need to I don't got this, or I don't know if I've got this, right? That in of itself can create a trauma or traumatic feeling and response. And so that often leads to a negative self-belief. When we are children, right, we're very egocentric, right? We've done these studies before that we think the whole world revolves around us because that's all we know, right? And so the common story is a kid who's growing up in a household where parents are fighting. Even if they're fighting about financial issues or other things, the kid thinks it's about them, right? My parents are fighting, it's me, I'm the problem, right? So when you have a traumatic event, we start to create these self-beliefs that, oh my God, this is me, this is why this happened. I am the reason this traumatic event is happening to me or around me, right? Which is pretty profound. And then we start to have behaviors that follow that self-belief, right? And oftentimes we recreate the traumatic events in our lives, right? The common example we talk about is battered or abused women syndrome, right? It is, we tend to be like, why do they keep going back to this? Why do they endure this? And the reality is, in my experience, is there's a self-belief. Oh, I can't see where it is now. It's very faint. There's a self-belief that they don't deserve any better, that they actually deserve this punishment, right? Somewhere along the lines, in my experience, again, commonly sexual abuse and sexual trauma is associated, but it could be you grew up in a house where you were physically abused. This was the norm. This is part of life, right? And that's why they endure it. And so they keep going back to it, right? If this is what I deserve, if this is the norm, why should I expect any different? Why should I look for any different, right? And so they end up back into it. So, it's often unconscious or subconscious, right? They're not thinking this aloud. Oh yeah, I was beaten as a kid, and so that's why I'm going to go into an abusive relationship. No, these are not conscious decisions in the vast majority of cases. So the big point I really want to bring up, what we learned from the adverse childhood experiences studies and the studies that followed, is we are all unconsciously reliving our traumas as well as the self-beliefs and patterns associated with them in a variety of ways. Right? I just want you guys to take that in because we're going to get into why I emphasize it's all of us. Okay? So I'm just going to talk about other conditions I've seen impacted by ACEs. Right? Chronic pain disorders. Right? Low back pain, joint pain, fibromyalgia, chronic regional pain syndrome, migraines. And we're going to go into the details of what kind of trauma tend to be that. Autoimmune disorders. And gastrointestinal problems, right? Whether it's motility or actually, we actually know that when you are exposed to a trauma, your gut bacteria change, your microbiome changes almost instantly, right? So IBS, acid reflux or GERD, Irma-GERD, gynecological, right? These are, again, not shockingly, based on what region of the body we're talking about, often associated with sexual trauma. I present this data, and I always get pushback from people, but the data's there. women who have PMS or premenstrual dysphoric disorder, 80 to 95% of them have a previous sexual trauma, right? How often has anyone ever, or who here has heard of the word PMS? Right? Yeah. And I can't say it. I guess I've lived it indirectly through my wife, but everyone's experienced it in some way, whether you are actually the one experiencing it or been on the other side of it. And just let that sink in. 80 to 95% of these women have had sexual trauma. The reason I bring this in, and the reason I bring this up, I often say to my patients, especially the ones who feel alone, thinking they're the only ones who've experienced this or one of the few, sexual abuse and trauma is the pandemic no one is really talking about, right? And this is not just a 1, 2, 3 year thing like COVID. This is an ongoing problem. And the fact that we're not talking about it, that we're not helping people understand that they're not alone in this, is preventing people from opening up and talking about it and getting the healing work done for them. This is not a comfortable topic, right? I totally understand that. I acknowledge that. I think in part because of the emotions it brings up just by me saying this, but it's so important for the healing of our communities. It's not just women, right? Men experience it too. They may not have PMS or PMDD, but you'd be surprised at the number of men who've experienced sexual abuse and trauma, right? So, and this is more of an extreme side note, in my opinion. Circumcision is actually a form of sexual abuse and trauma. Has anyone ever circumcised a baby before or seen a baby go through circumcision? I don't know if you've had this, but it is traumatic. We literally try to keep sugar in their mouths just to keep them from crying, right? That's hard. And so I just want to bring that up as a subtle note that we don't talk about these things, we don't think about these things, we're not going to address them, okay? I'm not saying don't ever, right? But it needs to be a conscious decision. In Africa, it's very needed to prevent STIs. In our communities, it's more of an aesthetic thing, but it's things to think about. So, other commonly associated with sexual or invasive trauma, that I try to use that term as well because having surgery and having a trauma associated with surgery actually manifests very similar to sexual trauma. So that's where invasive trauma can also be a gentler word to encompass kind of what we're talking about. And I often try to get that history from patients too. But we talked about morbid obesity, eating disorders, very common, right? And all images and associations about how we feel about our own bodies can be commonly linked. Kind of makes sense, right? If your body was used in a way for a certain thing, all of a sudden it makes you think about your body in a value sense. Fibromyalgia, pelvic pain, problems with sexual interest, either too much interest or too little interest, right? That can often be linked to that. Migraines, autoimmune disorders. The study, they talk about a study in the book where that is highly linked. Gastrointestinal disorders, interstitial cystitis or recurrent UTIs, there's a lot of overlap there. But people who continue to have UTIs, kids and adults, we have to be asking this question, was there a trauma somewhere? Endometriosis, again, we talked about these other things. Postpartum mental illness, I see this very common in women who have a female baby and all of a sudden, especially when they have no history, it's rare, but either an exacerbation or no history of mental illness, and all of a sudden it just really flares up. And there was nothing wrong with the delivery, everything went fine. They're bringing a girl into this world, in a world that they themselves, right, have encountered a trauma because of what they perceive as their gender. That can often bring it up. And then I very commonly see this in the LGBTQ plus demographic, right? And I think that's a conversation of itself, and why we see a lot of mental illness linked to this. I think partly it's how we treat that population as a society, but there's other elements too where there's a bigger vulnerability we may not be addressing. So what can we do? I'm going to start as a healthcare system because I'm coming here as a physician, not just another person, so it's my job to at least talk about what can I and our system do better. So one, I think this is important, for everything, but approach them with compassion and curiosity, right? We often hear the term trauma-informed care. If we're not compassionate, we're not curious, right? We have a high risk of re-traumatizing patients. Screen better, right? I think our clinic, our behavioral health part of our system does it. I don't think ACEs screening is really, I don't know if it's being done anywhere else. I'll just say that. I'd be surprised if it was done in, anywhere beyond us. I don't know if Child and Family Services does, but that's a good start to at least have an idea of who is being exposed to, or who's been exposed to what, or who in child and adolescence is being exposed to what, right? So for adults, obviously they've gone through their childhood, so you only need to screen once. For Keiki, it's important to do it annually. Their well child exam is a good opportunity to do that. If they're over 10, they should fill it out themselves. Under 10, the parents should fill it out. Ideally, they should fill it out honestly. It's hard sometimes for parents to even admit any things that they've been involved with. Physical abuse is probably the most common one, which unfortunately is quite common on this island. So, important to note, it's optional, right? We don't want, again, from a trauma-informed way, we don't want to force them to do something they don't want to do. And it's important to explain them. You're not just handing this a survey for just to kind of re-trigger them. This relates to their health, right? So ideally, you're having your nurse do that when they hand it out. I know that doesn't often happen, but at least hopefully you're bringing it in when they come in to do the assessment or the exam. And I think the benefit of verbal is helpful, because the paperwork is not always accurate. In both directions, but and listen to the patients if they're willing to talk about it, right? If they start opening up about it and you're like, we don't need to. Again, right? If part of their trauma is not feeling heard, we're again re-triggering them, re-traumatizing them. So really, if they're open to it, great. Listen, I always try to say, if you're open to talking about it, wonderful. If not, I totally understand. You let us know when you feel comfortable. And so when they did this study, they did a follow-up study where they would go through their ACEs and they would just say, I see that you've experienced this, right? Tell me how that's affected you later in life. That's all they said, and they just listened. And that intervention of itself reduced the number of unnecessary clinic visits 35% and ER visits 11%. Right? That was in the first year. The effect faded after that because I think there weren't interventions beyond that, and that's where we're going to be talking about as well. So I always like to give my analogy of how I approach health, right? As a psychiatrist, medications is part of my job, whether I like it or not sometimes. But the way I explain is medications, their role, in my opinion, should be to help you get you on your feet or maybe keep you on your feet if you're just struggling, right? If you can't get on your feet on your own. I give this rehab analogy, right? When you're trying to learn to walk again, so you had a stroke or an injury. But the important part is getting one foot in front of the other, right? If we want to get anywhere in life, it's one foot in front of the other. And one of the feet, I would say, is healing those wounds, these traumas that underlie our symptoms. And the other foot is lifestyle change. What are we doing day to day to get better? So, we want to help connect them to mental health resources, right? If they are still struggling despite therapy or other resources, maybe we need to think more about medication, depending on what the struggle is, right? Usually psychosis and bipolar disorder type symptoms are more likely to be a psychiatrist first, but we want to at least connect them to resources. And then I really emphasize the trauma-focused therapy, and the reason is, again, talk therapy, even if you're able to get insights into traumas and how they're impacting you, the actual processing of the trauma can't really happen just at a verbal level, right? And for some patients, it's just re-triggering to have to talk about it if they don't have the tools to heal it, right? And so these other modalities, EMDR, eye movement, desensitization, reprocessing, I know it's a mouthful, and brain spotting, which basically derived from that, are modalities where you're basically using bilateral stimulation, kind of like how we do in REM sleep, REM is when we dream. It's also when we store our memories from the day. And so what we're doing is using our biological technology to move that trauma from the fear center to where all the other memories are, right? In kind of more of a neutral place. Somatic therapy, where people have to get more into their body, right? And are able to process trauma through that angle. Internal family systems breaks us down into parts, right? Like when I get really angry, that's a part that's really trying to protect myself, right? It's a vulnerability as to why I'm angry. So let's work with that part that's angry. Why is he angry, right? And again, it often comes from that coping mechanism as a child. And when we do this work, you're like, oh, this is me when I was 10 or 13. And you can start to heal this inner child and these parts that feel a little fractured because of our trauma. Neurofeedback is a good way, again, just trying to help train your brain and your nervous system to be able to calm itself, right? This is all the rage these days with psychedelics. Ketamine's the medically approved one, but psilocybin, MDMA, all these things. And it's happening, whether the FDA has approved these other new ones or not. There's opportunities to heal and dig deeper using the advent of other drugs, like psychedelics. But again, using often with a therapist is where the healing can happen. And substance use treatment, right? If they're struggling with substances, it's hard to do the healing, especially if your coping is alcohol or drugs, right? You're just going to want to go back to that more, right? I have a patient yesterday who's trying to do this deeper healing work, but he's on benzodiazepines, which we've been trying to taper, right? Benzodiazepines, Ativan, Xanax, all those. They work very similar to alcohol, and he has a history of alcoholism. I see this very commonly. But he started using more of the benzos, right? Because he's trying to cope. And it makes it hard because it gets in the way of him being able to look at that trauma at a deeper level and really do the deeper work. Not to say you shouldn't do it at all, but you just have to be aware, are the substances getting in the way and how do we get them treatment for that? And again, psychiatric symptoms. For me personally, I try to lean away from medications when possible. Oftentimes when they're coming to me, usually someone's kind of deemed them a higher risk, not always. But for me, I've seen a lot of patients who go, I don't know if you need medications, but for the tipping points are usually if they're suicidal, right? I can only help them if they are alive and continue to be alive. And if they're having suicidal thoughts, the risk is there. Panic attacks, right? When you're so debilitated by your anxiety that you can't breathe, you feel like you're dying, right? How can you function and do this healing work at a deeper level? And then again, concerns of bipolar disorder, psychosis. And then eating disorders, body dysmorphia, if it gets to a certain point where physiologically they are just unable, right? I see this a lot in anorexia where their body just lacks nutrition to the point where they can struggle to move and function throughout the day. How do I expect them to do the deeper healing work and truly get better? And so a lot of times they need medical intervention to get them better to that point. So, all right. There's other modalities, massage, acupuncture, lomi-lomi, osteopathic manipulative therapy, which I always put in there because I do it. Shamanic healing, right? Ayahuasca is another psychedelic, which has been used traditionally for healing work. But really, any traditional or other healing practices that resonate with them and aren't harmful, right? Lifestyle. There's a list of different things here. I'm not going to go into all of them in detail, but the breath and connecting that back to your body is such a huge part of trauma work. Just feeling comfortable in your body, right? And not dissociating and feeling like you all need to be up here and think through everything. If we're not centered in our body, it's hard to do the healing work. Meditation, prayer, spiritual practice. I cannot speak enough about that. I tend to go really ad nauseum about spirituality. If we don't believe in something bigger than us, it's hard for us to feel supported and grounded, especially in times of stress. And I always say it's what you want it to be. It doesn't have to be a religion. Even if you were raised in a religion causes trauma. Just want to put that out, right? I hear laughter because people know. And some of the work I have to do with patients is helping them heal their religious trauma. This notion of a vindictive God who's going to punish you if you do this, that, or the other. Oh my gosh, as a kid, whew. And so trying to even help heal that so they can see what is their higher power? What do they see? Is it they connect to the universe? I want to encourage people to find their own path. There is no one path. I don't care what any religion says. Connecting to your community. That could be through religion and spirituality or faith. It can be, we have 12-step groups for people who struggle with addiction. There's 12-step groups for just about everything, right? Overeaters Anonymous, all sorts of lifestyle things that we all struggle with. Volunteering is a great way, helping others. But people who have just even similar interests or passions, just feeling part of a whole is so healing. Exercise. Exercise is so important in so many ways. Sleep, diet, creativity, nature. We live in one of the most beautiful places in the world. We should be utilizing it, right? So I'm going to bring you back to the trauma loop because there's a notion that I see sometimes when people feel really stuck. And it's because they have access, they're doing everything that they can, or they feel that they can, but they just don't get better. And I try to ask them these questions, and I have them answer from a heart space, right? Because the mind will come up with 20 billion answers to any of these questions. But from your heart, do you truly believe that you can get better, right? Because if that answer is a no, we're probably not going to. If you don't believe you can, it's hard, right? Believing is achieving. And then do you believe you deserve to be better, to be well, right? If there's a fundamental belief you don't deserve to, and I see this all the time, they get better, 2 steps forward, sometimes 3 steps back, right? They sabotage, they just get in their own way, it feels like. And it's because they believe they don't deserve it. So when they start to see it, they're like, oh, I don't deserve this. I gotta find a way to not do this. So, we want to help them with whatever trauma may be underlying that self-belief. And it could be both. So, this is how I approach it. I try to get as much history as I can. Again, we kind of talked about repressed trauma with invasive trauma. But just trying to bring this into the context, at least awareness of it, right? So what can we do as a community, right? How can any of us in this room help? So doing our own healing work, right? So for me, be the change you want to see in the world. If we're not doing the healing, it's hard to tell someone else to do it, right? Even if they're interested, it's like, well, how? I don't know. But you should do it. No, if you're doing it, share your experience, right? We all talk story and we all really relate to each other, and that's where a lot of change happens. And really, if you are doing better, the people around you tend to get better. I see it all the time, right? I think there's an energy component to this, right? When we bring in a positive energy, that can help shift a room or a space. So being aware when we're triggered by others, right? And for us in healthcare, including our own patients, because when we find ourselves judging others, right, that's a clear sign I'm triggered, right? I always say judgment is a sign of suffering. That is why we separate, right? That's where duality comes from. When we're in love, everything feels connected, right? So when we're frustrated or irritated, right, we're feeling amped up, we feel something in us. We could be triggered by something. Why am I feeling this way? Just ask, again, being compassionate and curious with yourself, right? When we feel resistance to others, rolling with resistance, right? Or trying to get a message and you feel like you're this, right? The one thing you can do is pull back and go, why am I butting my head against this, right? Why am I frustrated by this? Just being that curious part and recognize our own healthy patterns and self-beliefs. This one we're pretty good at least with the patterns, right? Oh man, I love my sugar. I eat too much. Right? All these different things. We can recognize this. We may not want to admit it with some of these things, but recognizing it and any self-beliefs that may come from that, right? This is where I find comfort. This is the only way I'm going to feel better. What is associated with this? Being curious as to what's underlying these reactions and exploring ways to process it, where you kind of went over some things. I always say, these are my suggestions. This is what I know, but be creative. You know you better than me. And again, being compassionate with ourselves, giving ourselves grace is so valuable. There's other cultural systemic changes. One of the studies, parenting classes, especially for first-time parents. For every $1 we invest in a parenting class, we as a society get $8 back. Right? Who would buy that stock? An 8-fold return. Right? Oh, only 1 or 2 other people? Come on. You guys must be really good at the stock market if 8-fold isn't enough for you. But we as a society should be investing in this, right? If we know that, because we reduce costs in jail, right? People going to jail, healthcare costs, institutional costs, right? The harm that these things can impact is tremendous. And if we just help parents help their kids better, we can be better. Talking openly with the kids about really sharing their uncomfortable experiences, right? Again, that support piece. If we can support kids right away, right after a stressful event, it doesn't feel as traumatic. We can reduce that trauma and its long-term impact on them. I always say use clear language, right? Especially when it comes to sexual trauma. I hear these stories of kids saying, oh, someone did this to my teddy, or whatever cute nickname they had of their private part that their parents taught them. Teachers don't know what that is, right? And if police are involved, they don't know what that is. Teach them clear language. I know we have this tendency because we feel uncomfortable about sexuality, especially with our kids. But if we can teach them this is a penis, this is a vagina, that can actually make sure that they can get the help that they need because they can communicate it, right? And that's on us as parents, as a society. And try to look at things through a lens of how our actions impact others, right? Especially kids. It's hard. I will say I think every parent does their best. I really do. Even the ones who are really just struggling and suffering in all these other ways. So I don't want this to be a burden or a weight on you. Just a point of reflection to pull back and go, okay, if I were to approach this kid this way, how would I feel if that was me as the kid, right? And just to help us soften how we approach things and be more compassionate towards them. And try to view ourselves, I put that first, because if we don't view ourselves through this lens, it's really hard to view others in a trauma-informed, non-judgmental way. If we're judging ourselves, we often project that onto others. Educate people about ACEs, their impact, and ways to heal from them, right? You may not have all the answers. Maybe you just take a couple of tidbits away from today's talk or from your own experiences, but whatever you share is a step in the right direction, and that's important. So, and I think, again, being creative, collaborating with each other, we are a collective, right? We're all in this together. And if we're collaborating and we're working together as organizations, as people, right? I mean, really, I want to implement this within our police departments, within our jail system. I mean, I hear the number of times people have been traumatized by these systems. They don't want that. I know they don't want that. The police don't want that. The jail guards don't want this. How do we help people be more trauma-informed and be more compassionate towards each other as a system? In our hospitals. I mean, our own hospitals traumatize people all the time. And we're never going to be perfect, but we can at least work on it. So, be creative. So I like to share this quote because I think it really encapsulates what we're trying to say here. When we give ourselves compassion, we are opening our hearts in a way that can transform our lives. By Kristen Neff. So, I'm not sure how much time we have, but I want to open it up to some questions, thoughts, discussion, anything. Yeah?
I'm Katrina Martinez. I wrote a research paper on ACEs several years ago.
Awesome.
It wasn't necessarily brought up, but how the actual brain changes from these trauma. And always just been really curious at what age, they always talk about the brain changing and such, and just if you had any input on how that is effective as adults get older.
Yeah. So I'm going to repeat the question for people who couldn't hear it. The question was, how does the brain change with the impact of these traumas and these adverse childhood experiences? And so, I'm always reticent to say anything that this is how it always happens. But the data show that you can see changes in the amygdala and the fear center. And we kind of talked about it with the frontal part of the brain that tends to be less prominent because we're so tapped into our primal brain. The executive function part of our brain tends to be less active and more diminished. And so that's where, we often see behaviors like impulsivity or kind of being more reactive or, all these things. It's almost like almost like a knee-jerk reflex. When they feel an emotion, they react because of these changes in the brain, we presume. Now again, if you are doing the healing work, we don't know what those changes look like. We don't have that data as to whether we can intervene to prevent these changes. I would speculate that it would, but yeah, good question. Anyone else?
One question over here. Would you like a mic or?
No, I got a lot of voice. Thank
Yay!
you, Dr. Kaleka, for your share. It's always very informative. I'm wondering, do we have any providers on the island doing EMDR work right now?
That's a great question. So the question is, do we have any providers on the island doing EMDR work right now? I just want to give a shout out to Christina Uemura and Amithia Love. They run the Kauaʻi Mental Health Consortium, and they actually have recently done a training free for many of these people to do EMDR training. So within the past few months, our numbers of therapists who do EMDR training has skyrocketed. I don't know the exact numbers, but I would say probably at least 30 or 40 attended the training, and there's already some trained before that. So, at least for Kauai, it's a great step in the right direction. Yes, Joe?
Yeah, I just want to add that you can look on the Kauaʻi Mental Health Consortium website, which is kauaimentalhealth.com, and you can actually filter by providers, and everybody's updating that for all these providers who have recently been trained. So you can search EMDR as a modality, and it will come up with providers accepting new people with their insurance and if they're doing EMDR too. So that's a great thing for folks to know.
I just want to clarify. So there's the Kauaʻi Mental Health Consortium website, I think you have to click trauma. I don't think there's a specific EMDR option, but trauma in terms of type of work that the therapist does. In psychology today, I know you can specifically pick EMDR as a modality or any of these modalities specifically if you're looking for that.
Yeah, they're adding the EMDR.
Oh, okay. Good to know. All right. Anyone else? Yes.
Thank you for today. Very informative. Love to see this coming to the surface and actually being practiced. And then asking for a friend, are you taking new patients?
So the question is, am I taking new patients? So currently my panel is, I say overall closed because we have a psychiatric nurse practitioner, Kanayo Sakai, who is excellent, that I would trust with my own family members. So I'm trying to help her build a panel. We also, on the addiction front, have Dr. Mailman, who's new and who's also excellent. We're trying to help them build up their panel. I'm booked currently through January. So for me, I just don't feel it's fair to expect patients who usually have a pretty significant mental health need to wait 4 or 5 months just to see me. And even if you do see me, then we're booking a follow-up that far out. So I try to do what I can to adjust, but I'm trying to minimize the stress on my staff to try to fit them in my schedule and also on the patients. So we'll see, to be decided in terms of psychiatry itself. I am still accepting people for chronic pain because that's a specialty that Dr. Choi refers as patients to me. There's a whole element that isn't just procedures, which is what Dr. Choi does. I also do autism evals because I know that's pretty limited, and some dementia evals. So I kind of make exceptions because not a lot of people on the island are really actively doing those things. Yes, Ray?
So the Mental Health Consortium, since you mentioned that, they have a website that lists all the different therapists and psychiatrists and so forth, and if they're available, if they're accepting patients or anything like that. So it's kind of like a current type of, they kind of keep it up so they know, who's available and who's not.
Yeah.
So I just kind of mention that real quick as a last question, and we're gonna wrap it up here.
Oh, sorry. Okay.
Any other questions though? Just want to make sure. Okay.
Thank you everyone for your time.
Mahalo, Dr. Kaleka. We are so lucky to have you. Will you be available for questions after? So maybe you can catch him outside as well. We are going to be, who's ready for a break? Yay!